Switching gears back to the pericardium, I've been asked to talk about the difference between constrictive pericarditis and restrictive cardiomyopathy. This is probably the most challenging and fascinating of the pericardial syndromes to me. I'm going to try to tell you the most important aspects of using the echo to make the diagnosis of constrictive pericarditis. I have no disclosures other than that I'm not a pediatric cardiologist, and maybe that's okay because I think we're asked this question a little more often than you are. Nevertheless, constriction can happen in children, particularly older children, and I think the same principles apply to making the diagnosis by echo in kids as it would in adults. So here's the pathologic difference, very obvious. These pictures are from Dr. Edwards at the Mayo Clinic. On the left, we have a constricted heart. So this is where the pericardium is sick. In many cases is always inelastic, and in many cases is thickened, calcified, fibrotic, and adherent to the outer surface of the heart, such that the heart cannot fill normally. And on the right, you have a heart that cannot fill normally because of a myopathic process. The muscle is sick. The muscle cannot fill normally. You can imagine, because of these pathologic differences, there's a fundamentally very important difference in how we treat the two disorders. You really don't want to miss the diagnosis of constrictive pericarditis because it's a potentially curable form of heart failure. Patients can become markedly improved with a pericardiectomy, or in some cases, in the case of inflammatory constriction, with anti-inflammatory treatment. So we need to pick up on this diagnosis and treat it, and we can help patients quite a bit. So what's the big deal, you say? I mean, they look very different there. The problem is that day to day, they look an awful lot alike. So these patients are both in their 50s, both women. Both have New York Heart Association Class 3 dyspnea, both have a tendency toward mild edema, and both have standard echocardiograms read as preserved left ventricular ejection fraction, no significant valvular heart disease. So are we done? Are they both types of heart failure with preserved ejection fraction? Do we simply give a diuretic and control the blood pressure and heart rate? Well, no. The patient on the left actually has constrictive pericarditis, and the patient on the right has restrictive cardiomyopathy. We can pick this up by echo, but it often takes a little more looking at the standard echo and possibly adding some components to turn your echo into a constriction protocol echo to really nail the diagnosis. The way we diagnose constriction is by recognizing that it has very unique pathophysiology, and Shobha covered a lot of this in the tamponade talk. They're actually quite similar. They're all part of the compressive pericardial disease spectrum. But in constriction, there's also a unique aspect of this dissociation of intrathoracic and intracardiac pressures, such that the pressures inside the heart do not track normally with the pressures inside the rest of the chest, and we'll talk about that. There's also the ventricular interdependence that was mentioned in the tamponade talk. The ventricles are trapped in a fixed space and can fill only at the expense of each other. Then there's some unique myocardial relaxation behavior and unique systolic behavior. Now, in pure constriction, which is what we're talking about today, we tend to think of the muscle being spared, and we think, oh, systole and diastole should be normal. Well, that's technically true, but it is affected by the adherent pericardium, and we'll talk about some of the unique fingerprints we can look for on the echocardiogram. And I'll tell you about what I believe to be the 6 key echo findings for diagnosing constrictive pericarditis. This concept of dissociation of pressures inside the thorax has been around since 1960 when Sharp and colleagues published this paper. It was subsequently sort of confirmed by Hatley and colleagues, Nishimura, et cetera, in the 80s and 90s. So let me just, it's a bit tedious here, but look at this line. This is the intrathoracic pressure that drops during inspiration. This top line is the pulmonary venous pressure, which also drops during inspiration. And this middle line here is the pressure within the heart. All of these are tracking normally in a normal person, such that the gradient to fill the left side of the heart, as marked by the vertical lines here, is preserved in inspiration. So you and I do not really drop our left-sided filling much during inspiration. Contrast that to the situation in constriction, or to some extent tamponade, where the heart is encased in an insulating rind of material, pathologic pericardium. So now we still drop the patient with constriction drops his or her pressure with inspiration in the thorax, drops the pulmonary venous pressure still because they're outside of the pericardium, but does not drop the intracardiac pressure to the same degree because the intracardiac chambers are insulated by the abnormal pericardium. So now your gradient to fill the left side of the heart has diminished significantly here, as marked by the vertical lines, and you do not fill your left heart to the same degree in inspiration. So you have phasic filling differences in the left heart in constriction because of the insulating pericardium. Shoba already talked about this. There's this other concept of ventricular interdependence, such that during inspiration, the right heart will fill at the expense of the left, and during expiration, the left heart will fill at the expense of the right. You can see the differences in relative sizes between the right and left ventricles in these two end-diastolic four-chamber frames. This is a video designed by Dr. Rowe at the Mayo Clinic to help us understand this. So here we're in inspiration. We decrease our left-sided filling and increase our right-sided filling. Now we're exhaling, we're increasing our left-sided filling, decreasing our right-sided filling, and the hepatic vein, which is a spy on the right heart, actually reverses its flow in diastole in expiration. So we'll watch this again. Inspiration, expiration. I'll let it play one more time here just so we can see it. Inspiration, drop your left-sided flow, augment your right-sided flow. Exhalation, restore your left-sided flow, decrease your right-sided flow, hepatic vein reverses its flow. So that leads us to our first key finding in constrictive pericarditis, which is that of the respiratory ventricular septal shift. This is based on those two key pathologic features I just told you about, and here's an example of four-chamber view in a patient with constrictive pericarditis. Watch the behavior of the septum as it shifts its position between the left and right ventricular free walls during the respiratory cycle. I'm not talking about the beat-to-beat shudder, sometimes called bounce, that you see also. That's a little harder to say is specific for constriction. I'm talking about the phasic shift in the position of the septum. This will require long clips, obviously, and an astute sonographer is key to this because a lot of these patients aren't referred for a constriction echo. They're referred for heart failure. And it's the astute sonographer who notices this behavior of the septum during live imaging and says, well, wait a minute, I need to get a 10-beat clip here, and I'm going to flag this study as, hey, I think there could be something wrong, something marking interventricular dependence. It may be subtle or it may be quite pronounced, as it is in this case. So that's the respiratory septal shift, which of course can also be seen by M mode with its superior temporal resolution. Here you can see this is a peristernal long axis. The septum is shifting toward the LV in inspiration and back toward the RV in expiration. You can use a respirometer if you have a good one, but you can also observe this without it. And then you can contrast the behavior of the septum in restrictive cardiomyopathy. You don't have that shifting of the septum in that disorder. So very unique to constrictive pericarditis here on the left. Which takes us to our next key finding in constriction, that of respiratory variation in mitral inflow velocity. We talked about this a bit in the tamponade lecture as well. Typically not as pronounced in constrictive pericarditis. We look for changes of about 15% between inspiration and expiration, as defined by expiration minus inspiration over expiration by convention. In any case, most of us just look at this qualitatively, and we try to see that in inspiration, marked here by the upslope of the respirometer, it's lower velocity than in expiration, marked here, number 2. You can also see changes in basically all of your Doppler flows, of course, but the mitral inflow has been best studied, as compared to restriction or other forms of heart failure where we do not expect to see that phasic change, that respiratory change in mitral E velocity inflow. And again, along these same lines, we talked about the hepatic vein reversing in diastole in expiration with constriction, and you can see that with pulsed wave Doppler. Here we see inspiration, as marked by increasing forward flow in the hepatic veins, transitioning to expiration, and you see this big reversal in diastole in expiration in constriction. And when you compare that to the forward flow in diastole, it can be used as a ratio to help make the diagnosis. But the concept is what's important here. So expiratory diastolic reversals in constriction, also seen by color M mode here, marked in red. We're in the expiration phase, we're in diastole, reversal of flow, as compared to restriction, in which we tend to see more prominent reversals of flow in diastole in inspiration. There is no shifting of the septum in restriction. The right heart cannot accommodate the increased flow that inspiration tries to bring it, so you reverse flow in the hepatic veins in restriction during inspiration. Now we're going to shift gears into this abnormal diastolic behavior, okay? So we use tissue Doppler to look at the velocity of the mitral annulus, and in most forms of heart failure, we see reduced motion of the mitral annulus. Constriction is different. We tend to see preserved or even increased medial E' velocities, and sometimes the medial E' velocity is higher than the lateral, again in contrast to normal patients and other patients with heart failure. This is another video from the Mayo Clinic to help us understand this. So the yellow dot in this normal patient is showing you a normal E prime type behavior. So the medial E prime is preserved and a little less than the lateral. In restrictive cardiomyopathy and most other forms of heart failure, you see diminished E velocity, reduced movement of that annulus, still a little lower than the lateral. And in constriction, things are quite different. The lateral is a little bit reduced because of the tethering of the pericardium out laterally, and the medial mitral annulus is almost trying to compensate for the fact that the heart can't fill, and it's becoming exuberant. So we can look for a preserved to increased medial E prime velocity in constriction, as shown here. So we have a medial E prime of 15 centimeters a second and a lateral E prime of 8 centimeters per second, as compared to restriction, in which we tend to see a quite low E prime of 4 centimeters per second in that range. So another very important tool to help us differentiate constriction from other forms of heart failure. Finally, systole is affected in constriction. The global EF is generally normal. Strain has taught us, though, that systole is not normal, and that makes sense, I think. If the heart is encased in pericardium, it's going to be hard for it to twist and shorten radially and longitudinally. We're going to focus on longitudinal strain here, since I think that's been the best worked out. So this is a bullseye pattern for longitudinal systolic strain, showing us what we expect, that global longitudinal strain is preserved in constriction generally, so minus 18%. But the lateral wall does not shorten to the same degree that the septal wall does, and I think that once again makes sense because the lateral wall is encased by this pericardium. So we see regional differences in the ability of the heart to shorten longitudinally because of that adherent pericardium. And that's in contrast to restriction on the right here, which tends to have a globally reduced longitudinal systolic strain. Here you see minus 12%. And you do not expect that significant difference between the lateral and septal walls. So putting the first 5 important criteria together, we did a blinded study of these in about 130 patients with constriction as compared to those without constriction, and found that these 3, respiratory septal shift, respiratory variation in hepatic vein reversals, and the preserved or increased septal E prime were the most important. Multivariable analysis, these were independently associated with the diagnosis of constriction. And if you see a septal shift and then either respiratory variation in hepatic veins or preserved or increased septal E, that seemed to yield the optimal combination of sensitivity and specificity, close to 90% for both. We did not routinely perform strain at the time of the study, so I don't know how that fits into it yet. Finishing up here, I didn't talk about the inferior vena cava or the mitral E to A, but we do expect that patients with constriction would have increased venous pressure and would therefore have some plethora of the IVC. And we do expect that the mitral E to A ratio would be at least 0.8, typically greater than 1. If neither of these is present, then constriction is unlikely. If these are present, then we go to our most sensitive finding, that of the ventricular septal shift with respiration. If that is present, then we go to the other 2 key findings I told you about, the medial E prime velocity and hepatic veins. If both are present, then you've essentially confirmed constriction. If one is present, constriction is still probable. If neither are present, well, constriction is still possible. Consider other studies if your clinical suspicion is high, hemodynamics, MRI, CT, etc. If the ventricular septal shift is absent, then we again look at those other 2 criteria, medial E prime and hepatic veins. If neither are present, then constriction is unlikely. If one or more is present, then again, constriction is possible, and you need to consider further study. Everything I've said comes from essentially these references here, and I thank you for your attention and hope this has been helpful.